So, good evening and a warm welcome to all the dignitaries present here. I'm Sreushi from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the Indian College of Anesthesiologists, and the focus of today's session is non-cardiac surgery in a cardiac patient update. So let's begin today's session, for which I would like to invite Dr. Muralidhar Kanchi sir to take over. Over to you, Kanchi sir. You can proceed with the talk now.
Thank you, Shreyasi, for that kind introduction. I'm speaking to you from Bangalore, and I happen to be the Dean of Indian College of Anesthesiologists. As you are aware, Indian College of Anesthesiologists was started as an offshoot of Indian Society of Anesthesiology in 2008. But from 2016, Indian College of Anesthesiologists is managed independently and is as of now no longer associated with Indian Society of Anesthesiologists. One of the important is its Wednesday webinars, which have become very popular event, and in fact, it has become a hallmark of Indian College of Anesthesiologists. And I'm grateful that the faculty today have agreed to be with us for the next 2 hours. And to begin the session, I would like to introduce my co-moderators. Dr. Manjula Sarkar, she is a very well-known cardiac anesthesiologist practicing in D.Y. Patil Medical College Hospital in Mumbai. Again, a renowned cardiac anesthesiologist from All India Institute of Medical Sciences, New Delhi. And then I have Dr. Keshav Murthy, who is my colleague, pediatric cardiac anesthesiologist with great experience in anesthetizing baby patients with heart disease. And then I will be with you till the end of the program. With that brief introduction of the panelists come moderator faculty, I would like to request Dr. Manjula to take over and conduct the session.
Thank you, sir, for kind introduction of mine. And as all of us knows that cardiac patients are always the problem for the non-cardiac anesthesiologist. So today's topic has been chosen for them. And the first speaker of this webinar is Dr. M. Karthik Babu. And his talk is going to be on cardiomyopathy patients, perioperative management, how we are going to manage. So without any delay, I would like to request Dr. Karthik to proceed for the lecture. Thank you.
Good evening, sir. Good evening, everyone. I would like to thank Dr. Murali, sir, for giving us the opportunity from GKNM Hospital, Coimbatore, to be a part of this wonderful webinar. My topic is about management of perioperative management of patients in non-cardiac surgery with cardiomyopathy. So the whole talk is you can scan the whole presentation in PDF. I would like to start the talk. Cardiomyopathy is defined as the myocardial disorder in which the heart muscle is structurally and functionally abnormal in the absence of coronary artery disease, hypertension, valvular disease, and congenital heart disease. So this classification of hypertrophic cardiomyopathy, dilated cardiomyopathy, non-dilated left ventricular cardiomyopathy, arrhythmogenic right ventricular cardiomyopathy, restrictive cardiomyopathy is taken from 2023 European Society of Cardiology guidelines. Dilated cardiomyopathy is defined as the presence of LV dilatation and global or regional systolic dysfunction. Hypertrophic cardiomyopathy can be defined as the presence of increased LV wall thickness, with or without or right ventricular hypertrophy or mass. Non-dilated left ventricular cardiomyopathy is defined as the presence of non-ischemic LV scarring or fatty replacement, regardless of the presence of regional or global motion abnormalities, wall abnormalities. Arrhythmogenic right ventricular cardiomyopathy is defined as the presence of predominantly RV dilatation or dysfunction in accordance with the published criteria depending upon the histological involvement and or ECG abnormalities. Restrictive cardiomyopathy is defined as restrictive left and or right ventricular pathophysiology in the presence of normal ventricular wall thickness. The other traits similar to cardiomyopathy are left ventricular hypertrabeculation, that's non-compaction, and Togut-Subo syndrome. So we saw the phenotypic classification of all the cardiomyopathies, but as anesthetists, we are worried about the functional aspect of all these types of cardiomyopathies. We all know there will be systolic dysfunction in this patient, the diastolic dysfunction in restrictive cardiomyopathy patient, obstructive cardiomyopathy in hypertrophic obstructive cardiomyopathy patients. So these are if certain fraction of patients, see all the restrictive diastolic dysfunction patient will be having some obstructive component. Obstructive HOCM patients will be definitely having some diastolic dysfunction. Systolic dysfunction, LV dysfunction patients will also be having restrictive diastolic dysfunction at the end, or if the filling pressures are high. So arrhythmogenic cardiomyopathy, arrhythmias may be present in any of these cardiomyopathies, and nothing comes alone. In all these patients, every component will be mixed. General principles in the management of cardiomyopathy are heart failure management, management of atrial arrhythmias, and management of ventricular arrhythmias. So let us see how to manage dilated cardiomyopathy. It's the most common type of cardiomyopathy. Right ventricular involvement will be there in these patients. It has got the poor prognosis, high mortality and morbidity. These patients are at risk of sudden cardiac death. These are the patients coming for heart transplantation more often. Dilated cardiomyopathy patients may exert exertional dyspnea and fatigue because of the LV dysfunction, and they may have right ventricular dysfunction features as well, like distension of neck veins and peripheral edema. The pathophysiology comes like this. There is a reduced forward flow because of the LV dysfunction. The increased ventricular end diastolic volume will be there. That causes increased ventricular filling pressure, which will cause further dilate the ventricles and further worsen the heart failure. The other thing should be kept in mind in this patient. These patients are prone for hypercoagulable state and land in intracardiac thrombosis. So this is reached by the heart failure patients have increased pro-inflammatory cytokines and increased plasma viscosity and increased number of platelets, which causes hypercoagulable states and thrombosis. And dilated cardiac chambers with dilated cardiac causes coagulation, activation, and fibrin aggregation and intracardiac thrombosis. Preoperative assessment of the patient, we should be worried about taking careful history and review the current medication of these patients. In ECG, the increase in the resting heart rate, wide QRS, left bundle branch block, and increased QT slope in these patients say the worst adverse outcomes, increased risk in these patients. These patients are at risk of sudden cardiac death due to non-sustained ventricular tachycardia. So Holter monitoring should be considered. The left ventricular end diastolic diameter of more than 58 millimeters in males and 52 in females is the diagnostic criteria for echo. As anesthesiologists, we should be worried about we should know about the systolic and diastolic function of both the ventricles. We should look for a ventricular aneurysm with thrombus and estimations of LA pressure, LV end diastolic pressure to know the diastolic grading of these patients with dilated cardiomyopathy, and we should know about the right ventricular status as well by TAPC. And By doing dopamine stress echo in this patient, we can come to know about the systolic reserves and the response to the drugs in these patients. So these patients, most of these patients, this is the indication for implantable cardioverter defibrillator in this patient. Any patients with NIHA 2 or 3 and a left ventricular ejection fraction of less than 35 in a dilated cardiomyopathy patient, that's a primary prevention indication for placement of intracardiac defibrillator. Implantable cardioverter defibrillator. So we should know the working mode and working status of the device. So we know that this electromechanical interference can happen with the peripheral nerve stimulators, with cautery, with evoked potential monitors. So these defibrillating function of ICD should be disabled at the time of surgery. Meanwhile, but we should be having external cardioversion defibrillation devices to manage the patient. X-ray may show pulmonary congestion, pulmonary edema, pulmonary hypertension, or pleural effusion. To know the ischemic coronary status of the patient, CT angiography or coronary angiography can be done. MRI is a useful tool to know the degree of fibrosis of the myocardium or extracellular volume quantification. These patients, the anemic, the blood transfusion threshold is no guideline recommending the transfusion threshold. But one study says that if the preoperative hemoglobin level is less than 12, the incidence of adverse cardiovascular event is more. Regarding the AC inhibitors in the patients, if it is indicated in patients without heart failure, this can be interrupted. We can stop the AC inhibitors in patients where the AC inhibitor is taken in patients without heart failure. If the patient is in stable heart failure and the indication for AC inhibitors is to prevent cardiac remodeling, we can consider continuing AC inhibitors, and that is a class 2B indication. As the LV dysfunction increases, with the ejection fraction decreases, we know the risk of surgery increases. About the timing of surgery, the low risk surgery and intermediate risk surgery have less than 1% chance for major adverse cardiac events. And in the patient with decompensated heart failure, the risk benefit assessment should be done before performing the surgery. Regarding the anesthetic management, we should avoid fluid overload, avoid sudden increases in afterload. We have to maintain adequate myocardial contractility and ejection fraction to perfuse the vital organs. Standard monitors like pulse oximetry, non-invasive blood pressure, and ECG is a must. But depending upon the type of surgery and the sickness of the patient, the arterial blood pressure monitoring, CVP monitoring, neuromuscular and transesophageal echocardiography, and even the PA catheter should be considered. Choice of anesthesia, we should know, depending upon the type of surgery and the severity of the disease, neuraxial, especially epidural, can be considered over spinal. And the choice of general anesthesia agent should be opioid-based anesthesia. Induction agents can be used. It can be supplemented with benzodiazepines. And we know the SVR reducing effects of the propofol and versus etomidate. So we know the indications for etomidate in proper patients. Ketamine though it is hemodynamically, it may cause stability for a short while, but it has got intrinsic negative inotropic effect and tachycardia. Inhalational agents should be used with less than 1 mAc. Inotropic support will be required in these patients with inodilators such as dobutamine, milrinone, and levosimendan can be used. Mean arterial pressure should be maintained more than 60 millimeters of mercury. Arrhythmia should be managed with drugs and defibrillation. Increased volume overload can cause pulmonary edema and heart failure. Insufficient ventricular filling, low volume can cause low vital organ perfusion. So all these should be assessed. The fluid status should be assessed with arterial blood pressure, central venous pressure monitoring, heart rate, hemoglobin, lactic acid, and urine volume monitoring to optimally balance the fluid. Transesophageal echocardiography is a boon nowadays to assess the volume status. The postoperatively multimodal analgesia is mandatory to avoid any adverse cardiac events in these patients. Next, going to hypertrophic cardiomyopathy. It's diagnosed by LV with a wall thickness of more than 15 millimeters of mercury in any myocardial segment. Physiologically, the dynamic LV outflow tract obstruction, mitral regurgitation, diastolic dysfunction, myocardial ischemia and arrhythmias, anything can occur in these patients with hypertrophic obstructive cardiomyopathy, and anesthetic should be cautious enough and ready to manage all these physiological, pathological manifestations in this patient. This is the classical dragger-shaped LV outflow tract continuous wave Doppler with late systolic peaking, producing a gradient of nearly 110 millimeters of mercury across the left ventricular outflow tract. These patients will be having mitral regurgitation because of the systolic anterior motion of the anterior mitral leaflet. And there will be a co-stuttering and premature closure of the aortic valve in a patient with HOCM. This is the classical posteriorly directed mitral regurgitation jet in a patient with HOCM. As anesthetists, we should be worried about this increased risk of sudden cardiac death in hypertrophic cardiomyopathy patients. Increased age, non-sustained ventricular tachycardia, maximum LV wall thickness, the history of syncope, increased LV diameter, and extent of increased extent of myocardial fibrosis by late gadolinium enhancement in MRI. These are the increased risk of sudden cardiac deaths. Adequate pre-medication that allays the anxiety of the patients is a must. Preoperative volume expansion should be done in these patients to reduce the incidence of hypotension and hemodynamic instability. Beta blockers and calcium channel blockers should be done. These patients are also, many of the patients will be having automated implantable cardioverter defibrillator, and as explained before, deactivation and reprogramming should be done. The monitoring can be done with directional arterial pressuring and CVP measurement. In these patients, the pulmonary capillary wedge pressure by PA catheter and CVP may not reflect the LV and diastolic pressure accurately. T is again the most useful monitor intraoperatively in patients with HOCM. During induction, any of these factors, anxiety, intubation, surgical incision, decreased preload, blood loss, or postoperative pain may increase the sympathetic stimulation and can cause hemodynamic collapse in patients with hypertrophic cardiomyopathy. Diastolic dysfunction is the predominant failure symptom in these patients with hypertrophic cardiomyopathy. So these patients should be managed with sinus rhythm. Sudden atrial fibrillation may require cardioversion. The hemodynamic goal should be slower heart rate, sinus rhythm, and maintain the preload and avoid decrease in the afterload in these patients. Induction of anesthesia will reduce the venous tone and preload and can cause increase in the LVOT obstruction and can cause hemodynamic collapse. So propofol should be avoided. Any drugs that causes SVR reduction should be avoided. Narcotics, opiate-based anesthesia is advised, and inhalation agents like isoflurane and sevoflurane less than 1 mg can be used. If the patient lands up in hypertension, rather than giving propofol or SVR decreasing drugs, we can treat that with increasing the plane of anesthesia, beta blockers, and we should avoid vasodilators. Hypotension should be treated by head-down position, volume expansion, and vasopressors like noradrenaline and vasopressin rather than chronotropic drugs. Neuraxial, it's a bit controversial, but if you understand the pathophysiology, epidural can be used, preferred over spinal anesthesia. And in non-cardiac setting, if cardiac arrest happens in this patient, it's very difficult to revive. These patients are at risk of myocardial ischemia, arrhythmia, and congestive heart failure during post-operative period. So high dependency unit carries required. The next thing is management of patients with restrictive cardiomyopathy. That's the diastolic dysfunction. There may be a dysfunction of right ventricle also in this patient. only at the end this systolic dysfunction occurs. Many parameters by echo to diagnose diastolic dysfunction. The one most important here is the E by E dash. If it is more than 14, that identifies the increased LA pressure and that takes it to grade 3 diastolic dysfunction. So in these patients, there is already increased LV wall stiffness. So there will be a steep diastolic LV pressure volume curve. There will be a steep diastolic LV pressure rise even with small increase in volume. So even a small increase in LV volume can cause increase in LV and diastolic pressure to a higher level, highest level, and that will increase the LA pressure, and these patients will develop pulmonary hypertension. As an anesthetist, we should, by echo, we should know about the right and left ventricular status of the patient, the degree of diastolic and systolic dysfunction, and we should know about the filling pressures. Even with high ventricular pressure, we have to maintain the fluid preload of the patient. So adequate filling pressure is a must. Sinus rhythm should be maintained, and SVR should be maintained because of the relatively fixed cardiac output. In these patients with restrictive diastolic dysfunction, general anesthesia will cause vasodilatation, reduce venous return, and myocardial depression, which all will further decrease the cardiac output. So positive pressure ventilation, which decreases the preload, is again aggravating the hemodynamic collapse. The perioperative management, these patients are at risk of complete heart block and ventricular tachycardias. Regional anesthesia should be avoided in these patients. Cardiac monitoring, maintenance of right ventricular filling pressure, and electrolyte disturbances should be addressed. The grade 3 diastolic dysfunction is associated with the highest mortality, that's with high LA pressure. The other things come along with this. These patients are at risk of postoperative atrial fibrillation, prolonged mechanical ventilation. These patients are at high risk of re-exploration and excessive bleeding. So these patients with diastolic dysfunction, there is an increase in LV end diastolic pressure, increased LA pressure, which further causes the RV dysfunction in this patient because of the pulmonary hypertension. Pulmonary hypertension can be pre-capillary or combined pre- and post-capillary hypertension. So this management of diastolic dysfunction is given by our teacher, Dr. Deepak Tempe. So the patients with pulmonary hypertension, whether it is pre or post-capillary, should be managed with PA catheter. We can use pulmonary vasodilators like nitric oxide, dobutamine, any lusitropic agent should be used. The similar lines of management for combined pre and post-capillary pulmonary hypertension as well. So we are coming to the end of the session. End of the slides. As anesthetists, we should be worried about, we should know about the functional status, whether it is systolic dysfunction, diastolic dysfunction, obstructive dysfunction, and arrhythmogenic. If the heart is there, arrhythmias will be there. And added to that is all these cardiomyopathies, which further increases the risk of arrhythmias. So in nutshell, in patients with dilated cardiomyopathy and systolic dysfunction, preload should be maintained even if the LVEDP is high, should avoid tachycardia, sinus rhythm should be maintained. We should increase inotropes, inodilators preferably to maintain the contractility. We should reduce the afterload, avoid increases in the afterload. In patients with hypertrophic cardiomyopathy, we have to maintain high preload, stable heart rate. We have to maintain the sinus rhythm, contractility. See, in obstructive cardiomyopathy, slight reduction in the contractility, the beta blocker is beneficial. We can increase or maintain the afterload. Restrictive cardiomyopathy, we have to maintain the preload. We have to maintain the heart rate because this fixed cardiac output status, high heart rate will help. Sinus rhythm is preferred, and inotrope, if required, can be used. Thank you, sir. Thank you.
Thank you, Dr. Karthik. And without wasting any time, now I can invite Dr. Kaushik Jothinath. He is a consultant pediatric cardiac anesthesia and intensive care from the same institution. And he is going to speak about anesthetic management of valvular heart disease for non-cardiac surgery. Dr. Kaushik, please.
Good evening, everyone. Am I audible?
Yes, you are audible.
Yes. So, without wasting any time, let's just go on presentation. So, over the next 15 minutes or so, I'm going to be talking to you about valvular heart diseases and anesthesia, in particular for non-cardiac surgery. So I have no conflict of interest to disclose, and all the clinical recommendations are based on current evidence-based practice guidelines. So I'm going to leave you with this again QR code for the next 10 seconds or so. You can scan it and have a PDF version of the same presentation. So we will be dealing with the four main pathologies as far as your valvular heart diseases are concerned. Let's dive straight in to the basic fundamental question. So we all know the race between the hare and the tortoise and who won. But hypothetically, what if the hare or the tortoise had a valvular heart disease? Who would then win the race? So to understand this, we have to understand that stenotic lesions and regurgitant lesions, they have a different hemodynamic profile. And therefore, as an anesthetist, your management goals would differ in both these lesions. So our first lesion would be, of course, mitral regurgitation, which is characterized by a retrograde flow. Your blood flows back from the left ventricle into your left atrium. So that is primarily what happens with your mitral regurgitation. So the key concept to understand here is that the left ventricle always prefers your pathway of least resistance. So you must always remember that the left atrium is a lot more compliant than your systemic circulation, which is a high resistance circuit. So given a chance, the LV would preferentially empty out into your low resistance left atrium. Another thing to be remembered in mitral regurgitation is that you never trust your ejection fraction, which you see in your echocardiography report. So, as anesthetists, we are always reassured by a good ejection fraction, which you see in your echocardiography report. But in your mitral regurgitation, that does not always hold true. The reason being that, again, your left ventricle, your ejection fraction is basically your end diastolic minus the end systolic volume, expressed as a function of the end diastolic volume. So you must always remember that in mitral regurgitation, the LV ejects blood into the low resistance left atrium. So the end diastolic volume is always increased. That is, the LV receives your pulmonary venous blood as well as the regurgitant blood during every cardiac cycle. And on the other hand, your end systolic volume is reduced because the left ventricle ejects into both your aorta and the left atrium. So eventually, your difference between the end diastolic and the end systolic volume increases, and therefore your ejection fraction is always increased in chronic MR patients until you have a cardiac failure and the LV actually begins to fail. So you always remember that in MR, when your MR is in play, the LV always finds the back door and empties out into the left atrium. So the key hemodynamic features as far as your mitral regurgitation is concerned is that you must remember that regurgitation, which occurs across the mitral valve, is occurring during systole. And therefore, your total left ventricular output is divided between the forward flow and your regurgitant flow back into the left atrium. So as an anesthetist, you're worried about what is the goals you're going to set during your non-cardiac surgery. You would always prefer a higher heart rate. You would maintain a sinus rhythm. You would avoid sudden increases in preload. You would reduce the afterload and try to avoid myocardial depression. So we will be looking at why each one of these goals is significant. The first being your heart rate. So as far as mitral regurgitation is concerned, you would always try to avoid bradycardia because your bradycardia tends to increase your diastolic filling interval. So you remember that the left ventricle tends to fill up with both the forward flow as well as your regurgitant blood, which is accumulating in the left atrium. And therefore, your increasing your diastolic filling interval would lead to further stretching of your mitral valve annulus. And over a period of time, it also tends to prolong your systole, which is actually the time when your regurgitation is occurring. So this in turn would lead to a reduction in the forward cardiac output. So you always try to maintain a high normal heart rate at around 90 to 100 beats per minute. So you remember that if you slow down things in your mitral regurgitation, you always end up going backwards. Now, what about your rhythm? Rhythm, you must remember that since your left atrium is dilating, these patients tend to have an increased incidence of atrial fibrillation. And therefore, if at all you have a sinus rhythm, you tend to try and maintain the sinus rhythm. And if your patient is already in atrial fibrillation, you tend to try and reduce your heart rate to controllable ventricular rates. So you target a heart rate of around 90 to 100 beats per minute again. So as far as your preload is concerned, you must remember that in mitral regurgitation, you tend to maintain an optimal preload. This is because your preload should be just enough in order to ensure an adequate forward flow and not excessive in order to avoid a left atrial over distension. Now, any sudden increase in your preload can in turn cause an annular stretch of the mitral valve annulus, and this would increase your regurgitant volume into the left atrium, which would in turn flood your pulmonary circulation and result in acute pulmonary edema. So as far as preload is concerned, you want to prevent your LAS button from popping in mitral regurgitation. Now, what happens to your afterload? So as we remember, you have two outflows from the left ventricle in your mitral regurgitation. One is your forward flow into the aorta, and one is your backward flow through the mitral valve into the left atrium. So you always try and reduce your systemic vascular resistance in order to improve your forward flow. And this would in turn promote your forward ejection into the systemic circulation. Now, how do you do that? You try to use systemic dilators if your pressures allow you to. And if your LV is down, your pressures are low, then you try to use inodilators. IABP as a last ditch effort. What is the role of neuraxial anesthesia in patients with mitral regurgitation? So, like we saw, mitral regurgitation patients always benefit from SVR reduction, and therefore your SVR reduction, which accompanies your neuraxial techniques, are usually well tolerated. And whenever possible, try and prefer an epidural. The next lesion of interest would be your mitral stenosis. Now, what happens in mitral stenosis is there is an anatomical narrowing of the mitral valve orifice, and this tends to restrict your blood flow from the left atrium into the left ventricle. So, what happens as a result of this? You have a stenosed mitral valve, and because of this fixed stenosis, your cardiac output is also fixed by the amount of stenosis that is present in the mitral valve. So this in turn tends to increase your left atrial pressure and would limit your left ventricular filling. So this is a nice, I just made it up, your blood trying to egress the left atrium through the mitral valve into your left ventricle. Now, like we saw with your mitral regurgitation, your mitral stenosis patients also tend to have an increased risk of atrial fibrillation. Now, we all know the conduction pathways. Your impulse, which is generated in the sinoatrial node, tends to go into the AV node, but before that, it spreads across into the left atrium as well through the Bachmann's bundle. When this sinoatrial node tracks its way through the heart and comes back when this impulse comes back to the sinoatrial node, the node is usually in your absolute refractory period. So it tends to prevent a further conduction of the same impulse. Now, what happens with your mitral stenosis or your regurgitation is that your left atrium tends to keep dilating. So your impulse, which is generated from the sinoatrial node, will get conducted through the Bachmann's bundle into the left atrium. And because the impulse has to travel through a larger area in the left atrium, when it comes back into the sinoatrial node, it will find it in a relative refractory period, or it will be sinoatrial node will be good enough to conduct the same impulse again. And this is primarily what happens in these valvular lesions involving the mitral valve, which predisposes them to your atrial fibrillation, beautifully described in as your circus movements. So now that the patient being pushed into your atrial fibrillation is usually the time that they present to you either for your surgery or with acute breathlessness for a medical management. So now what happens with your mitral stenosis? We all saw that there is a fixed obstruction that limits your left ventricular filling. And this in turn makes your diastolic filling time and the atrial contraction critical. We shall see why that happens. Your left ventricular filling is basically dependent upon a pressure gradient between the left atrium and the left ventricle. So whenever you have your mitral stenosis, the atrioventricular pressure gradient as such is extremely elevated. So your left ventricular preload therefore depends upon the mitral valve area. Now we all know the phases of your diastole. You have an isovolumetric relaxation phase, wherein there is no contribution to the LV preload from the left atrium. You have your early rapid filling phase, wherein you have a passive filling of the left ventricle from the left atrium across the mitral valve. And this is a phase that is most commonly affected due to your mitral stenosis because you have a stenotic mitral valve. So your passive pressure from the left atrium is unable to push blood into the left ventricle. Then, of course, you have your diastasis, which is again restricted due to the critical mitral stenosis that you have. And the last but not the least is your atrial systole, which is most critical in your mitral stenosis, and it gives you the essential kick to push the blood from the left atrium into the left ventricle. So one thing that we must remember is that whenever you have a fixed stenosis, like your mitral stenosis, or we shall later see in your aortic stenosis, your cardiac output is going to be dependent upon your heart rate because we all know that the cardiac output is a product of your stroke volume and the heart rate. So whenever your valve, your outlet valve is stenotic, your stroke volume is going to be restricted by that stenosis. And therefore, your cardiac output is going to be very much dependent on the rate that you set in these patients. So that is something which you need to remember as an anesthetist whenever you're dealing with a mitral stenosis or an aortic stenosis. Now, the anesthetic goals are you try and maintain a slow heart rate, therefore. You try and maintain sinus rhythm if the patient is not already in atrial fibrillation. You try and avoid sudden increases in your preload. You try and maintain afterload and maintain the contractility. We shall be looking at each one of these again. Now, as far as your heart rate is concerned, tachycardia is always detrimental in mitral stenosis. Now, the reason being that, like we saw, your cardiac output is a uh, product of your stroke volume and the heart rate. So, whenever you increase your heart rate in mitral stenosis, you're going to reduce your diastolic filling time for the LV. And when you do that, your LV is obviously going to be underfilled. So, you must remember that tachycardia always reduces your diastolic filling time, and therefore you want to avoid tachycardia in mitral stenosis. Your target heart rate would therefore be around 60 to 80 beats per minute in order to avoid a stampede in the LA. So as far as the rhythm management is concerned, again, you would want to maintain sinus rhythm as far as possible. If at all your patient is already in atrial fibrillation, then you would want to maintain a low normal heart rate. So again, your rhythm is important because you already have a reduced cross-sectional area for blood to transfer from the left atrium to the left ventricle. And we already saw that amongst your diastolic filling phases, the atrial systole is the one which is going to contribute the most to the cardiac output or your left ventricular preload or the left ventricular filling in mitral stenosis. So as far as your preload is concerned, in mitral stenosis, you would always want to walk a fine line between adequate filling and pulmonary congestion. Now, the reason being that in mitral stenosis, we already saw that there is going to be a high transvalvular gradient because your LA pressure is already elevated, and you would want to maintain this LA pressure in order to push the blood across a stenotic valve. However, if you tend to give a volume bolus, sudden volume bolus, what happens is that because your egress from the left atrium is already limited to the mitral stenosis, a sudden increase in your preload would end up flooding the pulmonary circulation instead. So as far as mitral stenosis is concerned, you would always be walking the tightrope as far as your preload is concerned. What about your systemic vascular resistance or your afterload? Must remember that in whenever you decrease the systemic vascular resistance, we all know that there is going to be compensatory tachycardia. And we saw what happens when you increase the heart rate in mitral stenosis. You want to reduce the diastolic filling time, and therefore that would lead to a hemodynamic compromise. Now, what about your neuraxial blockade role in mitral stenosis? So because your neuraxial blockades are associated with a drop in your systemic vascular resistance, these patients, they poorly tolerate your neuraxial blockade. And if unavoidable, you would tend to prefer peripheral nerve blocks or a graded epidural. Now, what would you do if you encounter a patient who has a hemodynamic instability with a mitral stenosis? So we try to normalize the volume slowly, of course. You would try to give in vasopressors such as your phenylephrine or vasopressin in order to increase the blood pressure and keep the heart rate under control. Avoid stimulants like your ephedrine. You would restrict the heart rate of the patient by using beta blockers or digoxin, and inotropes if in case the patient has a secondary RV dysfunction in the form of Milrinone. Now, the next lesion of interest is your aortic regurgitation. Now, you must remember that your aortic regurgitation occurs during diastole. There is going to be a retrograde flow from the aorta into the left ventricle, as opposed to your mitral regurgitation, which occurs during systole. Your aortic regurgitation is happening during diastole. Now, what happens as a result of this? The blood flows back from the aorta into the LV. This would cause a volume overload on the left ventricle. The left ventricle tends to dilate in order to accommodate that extra volume. This would lead to an eccentric hypertrophy. And again, like we saw with regurgitant lesions, there is going to be a divided left ventricular output. Over a period of time, the left ventricle would fail, and that would in turn result in a decreased forward flow. So as far as the hemodynamics in aortic regurgitation is concerned, you would want to reduce your regurgitation by shortening the diastolic duration, ensure sufficient blood volume for an effective cardiac contraction, and facilitate your forward flow from the heart into the aorta. Again, we'll be looking at each one of these goals individually. As far as the heart rate is concerned, like your mitral regurgitation, the bradycardia in AR also is detrimental. The reason being that bradycardia would tend to increase the duration of diastole. And we all know that regurgitation is occurring during diastole in aortic regurgitation. So which means that a longer duration of diastole would mean that there is more time for the regurgitation to occur, which would in turn lead to a higher regurgitant volume. So you always want to maintain the heart rate at around 80 to 100 beats per minute. As far as the preload is concerned, you already are tackling a patient with a high left ventricular volume because of that eccentric dilatation. So your LV end diastolic volume is already elevated in a baseline state. So any sudden increase in the preload would further worsen your LV distension and increase your aortic regurgitation, may push him to a failure state. As far as your afterload management is concerned, we all saw, like in mitral stenosis, you want to, mitral regurgitation, you want to reduce your afterload in order to increase your forward flow of blood. So how do you do that? You would use systemic vasodilators again, if your pressures allow you to do it. Inodilators, we must remember that unlike your mitral regurgitation, your IABP is contraindicated in severe AR. And always try and maintain or deepen your anesthetic lanes with volatile agents. As far as contractility is concerned, we saw that you have an eccentric hypertrophy in your aortic regurgitation. So you always want to maintain your LV contractility in order to ensure that there is a efficient ejection, forward ejection of blood from the left ventricle. So the physiological basis for this being that your left ventricle is already volume overloaded and it relies on an enhanced contractility to maintain your forward flow. That is your Frank-Starling mechanism. This initially compensates for your volume overload. Over a period of time, the LV tends to decompensate and increase the severity of regurgitation. So clinically, you would want to avoid myocardial depressants whenever possible. Titrate your anesthetics carefully. Consider additional inotropic supports and whenever it is possible. As far as your neuraxial blockade is concerned, your neuraxial techniques like for mitral regurgitation are usually well tolerated for regurgitation because your systemic vascular resistance is going to reduce and therefore your forward flow is going to increase with your neuraxial techniques. Now, what do you do if you encounter a patient undergoing a non-cardiac surgery with hypotension and aortic regurgitation? So you'd always prefer ephedrine because it increases the contractility as well as the heart rate. You would want to avoid sudden volume boluses. You would want to institute your inotropes early in order to minimize your left ventricular end diastolic volume and the end systolic volume. Inodilators are preferred, such as your dobutamine and milrinone. And remember, there is no role of a IABP. So the next lesion, of course, is your aortic stenosis. And like we saw in the previous picture, your heart is going to be pumped up like your Ronnie Coleman. So there is going to be an anatomical narrowing of the aortic valve orifice, which restricts your blood flow from the left ventricle into the aorta. And like your mitral stenosis, again, you have a stenotic aortic valve here. So your cardiac output is more or less fixed. So when you have a fixed cardiac output, as a result of which you have a fixed cardiac output. And the stenotic aortic valve tends to result in a concentric left ventricular hypertrophy. Now, clinically, your aortic stenosis patients are the ones who have a highest risk of adverse perioperative cardiac outcomes. So these are your anesthetic goals for your aortic stenosis patients. We shall be looking at each one of them in detail. As far as your rhythm is concerned, again, try and maintain your sinus rhythm in these patients. The reason being that your with a stenosed aortic valve, your LV is going to be grossly hypertrophied, like we saw in that echo loop. So when your LV becomes grossly hypertrophied, it also becomes poorly compliant. So this would result in a high LV end diastolic pressure, which would make it non-compliant. So therefore, your pressure gradients across the mitral valve are going to automatically reduce. And as a result of which, your left ventricle is going to be dependent more and more on the atrial kick for its preload. So your atria contribute almost 50% to the LV stroke volume in patients with your aortic stenosis. So maintenance of sinus rhythm is a key priority in aortic stenosis patients. And this is one reason why you would want to avoid triggering of ectopics whenever you're inserting a central line. Because what happens in your aortic stenosis is that there is a huge gradient between the uh, left ventricle and the aorta because of your stenotic aortic valve. So if you end up triggering off ectopics, more often than not, this ectopic run would result in a sustained ventricular tachycardia because the coronaries arise distal to your stenotic aortic valve. So if in case you have a sustained ventricular tachycardia, then you're going to have a really difficult time trying to revive this patient because the amount of chest thrust that you will have to give overcome your aortic stenosis and generate a forward flow through the aorta during your CPR would be extremely high. Therefore, you would want to avoid triggering of ectopics whenever you're inserting a central line in these patients. Other things to remember is that you would want to maintain the heart rate. Avoid tachycardia because tachycardia tends to increase your myocardial oxygen demand, as well as avoid bradycardia because we all saw that the stroke volume is fixed Your cardiac output is dependent, therefore, on the heart rate. So if you drop your heart rate, your cardiac output is going to fall. Ideally, you would want to maintain it around 50 to 60 beats per minute. As far as your preload is concerned, unlike the other valvular lesions, your aortic stenosis patients, they usually tend to tolerate your preload as long as your heart has not failed, and you would end up creating a pulmonary edema in those patients. So whenever your aortic stenosis patients are there, you would treat your hypotension with volume first and foremost. The reason being that your LV tends to hypertrophy and becomes poorly compliant, and therefore would require a high filling pressures for it to maintain your cardiac output. So it more or less is like in a mukbang phase. So the role of your neuraxial blockade, you would want to avoid neuraxial blockades as far as possible, because your reduction in SPR will be poorly tolerated in aortic stenosis. The reason being that it would precipitate a profound hypotension, and you would also find it difficult to titrate your sympathectomy levels. Now, as far as hypotension in aortic stenosis patients is concerned, you would prefer giving phenylephrine or norepinephrine or vasopressin or fluid boluses as the first choice. And try and avoid inotropes because it tends to increase your myocardial oxygen demand. Now, more often than not, you're faced with a scenario wherein in aortic stenosis patients, you're managing a hypertensive patient. What do you do in those patients? You would definitely want to avoid nitroglycerine. The reason being that your NTG tends to reduce both your systemic vascular resistance as well as a preload, and this may cause a precipitous hypotension. Again, your coronary perfusion pressure is nothing but the difference between your diastolic pressure and the LV end diastolic pressure. We already saw that the LV end diastolic pressure tends to go up in your aortic stenosis, and if you give your nitroglycerine and drop the diastolic blood pressure, then your coronary perfusion pressure is going to dip, and therefore this is the reason why you would want to avoid nitroglycerine for managing any hypertensive crisis in a untreated aortic stenosis. Preferred approach, of course, would be to use beta blockers. And sorry state at the end of it all, Ronnie Coleman, this is how he is at present. This is how the heart also tends to become over a period of time. So you need to evaluate how long the aortic stenosis has been present and the left ventricular function. So as far as your echocardiography is concerned, you would want to use your echocardiography to confirm the valvular pathology, evaluate your ventricular function. Of course, don't be fooled by your ejection fraction in your regurgitant lesions. You would want to assess the pulmonary pressures and use it as a guide for your anesthetic planning. And as anesthetists, also concerned about which patients should receive your infective endocarditis prophylaxis. This is a nice guidelines which came out in 2023. Please do have a look. Uh, it defines what are the patients who you would want to give a IE prophylaxis for. Any patient with a previous IE, any patient with a surgically implanted prosthetic valve, or a transcatheter implanted valve should receive your infective endocarditis prophylaxis. And as far as your congenital heart disease are concerned, any untreated cyanotic congenital heart disease or a patient who has received a treatment but who has a residual lesion. These are the patients you would want to give an infective endocarditis prophylaxis. What are the procedures for which you would give it? The recent guidelines tends to uh, increase your spectrum of patients who are covered with your IE prophylaxis to dental, any patients who is receiving a respiratory or a gastrointestinal or a genitourinary tract intervention as well. The antibiotics given are your ceftriaxone or cefazoline in patients who are allergic or non-allergic to penicillin. So to summarize, your race between the hare and the tortoise, whenever they have a cyanotic or a regurgitant lesion, is always not very simple. For a stenotic lesion, you would prefer the tortoise. You would bet on the tortoise to win. For your regurgitant lesions, more often than not, your hare would win, and therefore you would want to maintain a higher heart rate, a sinus rhythm, maintain your adequate preload and reduce your afterload for regurgitant lesions. In stenotic lesions, prefer a low normal heart rate, sinus rhythm whenever possible, maintain adequate preload, and maintain your SVR. So the decision about regional versus general. For stenotic lesions, regional is usually, your neuraxial blockades are usually not tolerated well. Your regurgitant lesions tend to tolerate them better. So this is your matrix for valvular heart diseases. I think we've covered each one of them in detail, so I'm not going to harp on this. And of course, you can scan to have a personal copy of this. Thank you.
Thank you, Dr. Kaushik. Now, I would like to invite our next speaker of this webinar, Dr. Anusha. She's cardiac consultant and she's going to talk about cardiomyopathy patients coming for LSCS. And all of us knows that LSCS is a real problem. Young patients, a major cardiac event can occur. These patients are asymptomatic for the cardiomyopathy is concerned. Even investigations are not going to tell us much about that. So over to you, Dr. Anusha, for this lecture. You have to unmute yourself.
Can you hear me, ma'am?
Yes, we can hear you. Yeah.
Can you see the slides, ma'am?
We can see your slides. You have to make it fully screen.
Yeah. Good evening, everyone. I'm Dr. Anusha, consultant anesthetist, GKNM Hospital. I thank the ICA team and Dr. Murali sir and the moderators for this opportunity for participating in this webinar. My topic is management of peripartum cardiomyopathy in a patient coming for LSCS. As we all know that peripartum cardiomyopathy is a de novo heart failure occurring towards the end of pregnancy or in the months following pregnancy, and it is marked by left ventricular systolic dysfunction. In this talk, I'll be discussing history, definition, incidence, etiopathogenesis, clinical features, diagnosis, management, and anesthetic consideration. Coming to the history, as early as 1800, which show explain heart failure associated pregnancy in the peripartum period. The first large case series was published in New Orleans in 1937, and the term peripartum cardiomyopathy was first introduced in 1971 by Demarquis and Rahimtullah et al., and they published data on 27 patients in the peripartum period. Coming to the definition of peripartum cardiomyopathy, the European Society of Cardiology has given a definition of heart failure occurring secondary to left ventricular systolic dysfunction with an ejection fraction less than 45%, occurring towards the end of pregnancy or in the months following delivery with no other identifiable cause of heart failure. Incidence, unknown true prevalence. It varies markedly depending on the geographic and ethnic background. We can see in the slide that in Nigeria, the incidence is 1:1 or 2 live births, whereas in Japan, it is almost 1:20,000 live births. So it varies. In India, there was a study published in the Journal of Clinical and Preventive Cardiology where the incidence was reported as 1:1340 live birth with a maternal mortality of 11.7 and fetal mortality of 14.2. Coming to the risk factors of peripartum cardiomyopathy, the maternal risk factors are increased age, high parity, African ethnicity, preeclampsia, selenium and zinc deficiency, HIV infection, previous history of peripartum cardiomyopathy, smoking, diabetes, and multiple pregnancy, artificial reproductive techniques, use of prolonged tocolytics, and high prolactin level is also associated with it. We should also remember patient with gestational hypertension or preeclampsia will present with a threefold increase in risk of peripartum cardiomyopathy. The pathogenesis, we have to remember that the onset of cardiomyopathy does not coincide with the hemodynamic changes of pregnancy. As we can see in this slide, the graph, the plasma volume, the cardiac stroke volume, the cardiac output, the cardiac mass all increases in the mid gestation, whereas PPCM develop in late gestation or after delivery. It usually occurs in clusters in families, so we could make it a point that there is a strong genetic predisposition, and analysis identified variants in gene that encode sarcomeric proteins like titin, myosin, and troponin. And TTN variant gene, which encodes titin, has been mutated, and it is predicted to have found with lower AF at 12 months. So this is also seen in 13% of Black women, which could be one possible explanation for the worst prognosis in these males. This is the slide which tells you the mutation which is present in patients with peripartum cardiomyopathy. In 2007, a study suggested that prolactin, a 23 kilodactyl protein secreted by the anterior pituitary, plays an important role in pathogenesis of peripartum cardiomyopathy. Genetic susceptibility, oxidative stress causes the cardiomyocyte to release cathepsin D. Cathepsin D will cleave prolactin to form a 16 kilodactyl prolactin fragment, and that acts on the endothelium, causing dysfunction. The endothelium will release microRNase 146A, which causes cardiomyocyte apoptosis and death. In addition, the placenta also secretes anti-angiogenic factors like FLT1 and activin A. These two are causing endothelial dysfunction and cardiomyocyte dysfunction. PGC1 alpha, which is actually promoting angiogenesis and reduces oxidative stress, is actually markedly reduced in peripartum cardiomyopathy. It can also, myocarditis, an autoimmune mechanism, has also been suggested to cause peripartum cardiomyopathy. In a nutshell, genetic susceptibility, infections like myocarditis, autoimmunity, placental anti-angiogenic factors, oxidative stress cause angiogenic imbalance, which results in endothelial dysfunction, cardiomyocyte apoptosis, and peripartum cardiomyopathy. What are the symptoms? The symptoms usually is weight gain, extreme fatigue, shortness of breath. Patient can present with dyspnea, orthopnea, paroxysmal nocturnal dyspnea, edema. The problem is this is present even in normal pregnancy, which might be difficult to diagnose peripartum cardiomyopathy. In addition, patient may have chest pain, cough, rapid heart rate, or even they can present to us with symptomatic or unstable arrhythmias. Less commonly, they can even present us with cardiogenic shock. On physical examination, there will be tachypnea, tachycardia, raised JVP rails, and peripheral edema. Investigation, ECG shows sinus rhythm with non-specific ST-T segment changes, ectopics, brady or tachyarrhythmias. Chest X-ray can show pulmonary edema, enlarged cardiac still out, or pleural effusion. Usually BNP, NT-proBNP, and troponin will be raised. And the gold standard for diagnosis is echocardiographic evidence of LV ventricular dysfunction with an ejection fraction less than 45, but often associated with ventricular dilatation. We should also remember that we have to do repeat echo in these patients. One is to monitor the progression of LV dysfunction, and second is to identify the complication of intracardiac thrombus. In the first picture, we can see that the LV is markedly dilated, and the second, there is a thrombus. What are the differential diagnoses? There can be a pre-existing cardiomyopathy, or it can be pre-eclampsia-induced pulmonary edema, or it can be a pulmonary or amniotic fluid embolism, or it can be a chemotherapy-induced cardiomyopathy. But any pregnant patient who present to us, or any postpartum patient presenting us with heart failure symptom, with an echographic finding of ejection fraction less than 45, and there is no structural heart disease, the the likelihood of peripartum cardiomyopathy is very high. What are the factors which are associated with poor prognosis? If the ejection fraction is less than 30% and if the left ventricular end diastolic diameter is more than 6 centimeters and if the diagnosis is made 1 week after the onset of symptoms with RV dysfunction and LV thrombus of the patient presence, and if the patient has a previous history of peripartum cardiomyopathy or simultaneous preeclampsia with raised troponin, NT-proBNP, SFLT levels, then the prognosis is very bad. Obesity and African ethnicity also is associated with poor prognosis. What is the management? Management will broadly mirror those with other forms of heart failure like adequate oxygenation, fluid restriction, ventricular offloading by vasodilatation and diuresis. A multidisciplinary team with an individualized management, because if the patient is presenting during late pregnancy, we have to take into account the gestation, the fetal viability, and the risk of pregnancy continuation of the maternal health. Or if the patient is present to us postnatally, then we have to think about the implication of lactation on the disease progression and safety of medication in breastfeeding. If a patient is coming to us with acute cardiopulmonary decompensation, first optimize preload, IV diuretics for pulmonary congestion, and if systolic arterial blood pressure is more than 110, a vasodilator can be added. Correct hemodynamic instability, optimize oxygenization. Thromboembolism and anticoagulation, there is increased risk of LV thrombus, so prophylactic anticoagulation to be started. Or if the patient already has an intracardiac thrombus or present to us with an AF or systemic embolization, therapeutic anticoagulation has to be started. Things to be remembered is low molecular weight heparin can be given both during pregnancy and lactation. Warfarin is best given only during lactation. There is high risk of arrhythmias and sudden cardiac death, particularly if the ejection fraction is less than 35%. Cardioversion and defibrillation is safe during pregnancy. Usually, LV function was improved within months of optimal treatment, so ICD will be not necessary in most of the patient. ICD will be indicated only if the patient has severe LV dysfunction even 6 months after diagnosis and optimal medical management. Mechanical circulatory support and cardiac transplantation may be required in patients with severe cases of peripartum cardiomyopathy. VADS or ECMO may be required during the initial hospitalization if they present in a cardiogenic shock. And cardiac transplant in patients with severe LV dysfunction even after optimal treatment. And this is a 2018 European Society guidelines for management of cardiovascular disease during pregnancy. The heart failure medications which can be given during pregnancy and lactations are loop diuretics, beta blockers, hydralazine, nitrates, and digoxin. AC inhibitors, ARB, and aldosterone receptor antagonists can be started during lactation. 2018 European Society of Cardiology guidelines recommended bromocriptine to be considered in patients with newly diagnosed peripartum cardiomyopathy. And they have also found that the bromocriptine gives high LV recovery rate and no mortality or requirement for LVAD or heart transplant. But the problem is there is increased thromboembolic risk, so prophylactic anticoagulation has to be started. In May 2025, International Journal of Cardiology has also given a systematic review and meta-analysis where the safety and efficacy of bromocriptine has also been the same. In European Journal of Heart Failure, the board scheme of for treatment management of peripartum cardiomyopathy has been devised, where board is a mnemonic and B stands for bromocriptine, O stands for oral heart failure drugs, A for anticoagulation, R for relaxant, and D for diuretics. The dose of bromocriptine is like if ejection fraction is more than 25, it will be 2.5 milligram OD for 7 days. If it is less than 25%, then it will be 2.5 milligram BD for 14 days, followed by 2.5 milligram OD for another 42 days. And if the patient is in cardiogenic shock with ventilatory and circulatory support, then bromocriptine can be started with 2.5 milligram BD, and it can be titrated up to a maximum of 10 to 20 milligram depending on the serum prolactin level. In a nutshell, the patient is coming with mild peripartum cardiomyopathy where there is the patient is stable with mild pulmonary congestion and ejection fraction is 30 to 45%. Then you can treat them in the ward with oral and heart failure drugs, oral diuretics, and bromocriptine for 1 week. And if the patient present with moderate peripartum cardiomyopathy with acute heart failure but hemodynamically stable and pulmonary congestion with ejection fraction of 20 to 35, then patient will be treated in intermediate care or high dependency unit with IV diuretics, vasorelaxant, supplemental oxygen, bromocriptine for 8 weeks, and oral heart failure drugs. If the patient is presenting as with severe peripartum cardiomyopathy and cardiogenic shock, then patient with ejection fraction less than 20 to 25%, then treat them in ICU with diuretics, heart failure medications with invasive ventilation, mechanical circulatory support as and when needed, and bromocriptine up to 8 weeks. Coming to the anesthesia and analgesia during labor and delivery. If a patient with peripartum cardiomyopathy is hemodynamically stable, there is no absolute indication for cesarean section obstetrically, then you can continue pregnancy till term, assist vaginal delivery with labor epidural analgesia if there is no neurological coagulation abnormality. Shorten the second stage by episiotomy, vacuum, or forceps. Most important thing is to prevent fluid overload during labor and post-delivery. If the patient is not hemodynamically stable, or if there is an obstetric indication for cesarean section, then early termination of pregnancy by cesarean section can be done either under spinal or under general anesthesia. For neuraxial anesthesia should be instituted early in labor. Most important thing is continuous close monitoring. And in addition to ASA standard monitoring, arterial BP monitoring is mandatory for even neuraxial analgesia. Labor epidural can be started with standard local anesthesia, local anesthetics and opioid infusion, but to be given cautiously in incremental dose. Anesthesia for cesarean can be done with epidural, low-dose combined spinal epidural, or general anesthesia. Goals will be to maintain myocardial perfusion, avoid hypotension, arrhythmias, tachycardias, optimize cardiac output, maintain preload, prevent fluid overload, maintain contractility, prevent increased afterload, avoid acidosis, hypoxemia, and anemia. Most important thing during GA is continuous arterial pressure monitoring and a central line for administration of vasopressors and inotropes. During GA, obtain the pressure response to laryngoscopy and intubation with opioid. So basically an opioid-based anesthesia. Hypotension, give vasopressors, inotropes and inopressors will we give determined by the patient's clinical condition, arrhythmias to be treated appropriately. Most important thing is cautious fluid administration and closely monitor the blood loss, and cautious during autotransfusion because it may lead to acute decompensation. Early active management of third stage of labor to prevent uterine atony and bleeding. Oxytocin can be given, but rapid bolus to be avoided can be given as an infusion. Misoprostol, though less effective, can be considered if because of fewer cardiovascular side effects when compared to carboprost or ergometrin. Postoperatively, monitor them in HDU, ICU, continuous close monitoring of vitals, fluids, and continuous heart failure medication with adequate multimodal pain management. Recovery and outcomes. The full recovery of peripartum cardiomyopathy, that is the ejection fraction more than 50 to 55% at 6 months, varies across different regions of the world with reported rates ranging from 21 to 63%. Early mortality or sudden cardiac death will be secondary to cardiac arrhythmias, acute heart failure, or thromboembolic events. Later mortality will be due to worsening LV function and chronic heart failure. Contraceptions will be due with use of low-dose progesterone. The most important thing to remember is guideline-directed heart failure therapy should be continued for at least 1 year after LV function has been completely recovered. What about subsequent pregnancy? If the patient has a peripartum cardiomyopathy and the persistent LV dysfunction, there is a high risk that there is increased mortality and morbidity with subsequent pregnancy for the mother, and there can be premature delivery and abortion for the fetus. If the patient has been completely recovered, there can be better prognosis, but more than 20% will have a relapse and may or may not have a normal pregnancy. Whatever, whether they have LV dysfunction or not, the patient should be carefully, closely monitored by both obstetrician and cardiologist. This is illustration which has been published in American Cardiology, where they have given the definition, the risk factors, symptoms, the management for outcomes and long-term outcomes of peripartum cardiomyopathy. Summarizing, early and prompt treatment by multidisciplinary team will reduce the morbidity and mortality. Treatment will mirror the heart failure management. We have to continuously and closely monitor the vitals with low threshold for vasopressors, inotropes, and invasive BP monitoring. Initiation of neuraxial analgesia, if so, in early labor. For LSCS, we can go for combined spinal, epidural, or GA. Most important thing, maintain fluid balance, uterotonics to prevent PPH. Consider bromocriptine and venous thromboembolic precautions after delivery, and continue treatment and follow-up even after 1 year of recovery. Thank you. These are my references.
Thank you, Dr. Anusha, for that exhaustive presentation about peripartum cardiomyopathy and its management. Now it's my turn to call upon Dr. Maithriye to associated congenital heart diseases. So Dr. Maithriye is a junior consultant at GKM A&M Hospital, and she is the DRNB student from Narayan Hridayalaya. Very proud of her. Very intelligent, smart, and hardworking anesthesiologist. Over to Maithriye to present the topic.
Thank you, sir. Good evening, all. Today we will be looking into the anesthetic management of pediatric congenital heart disease coming for a non-cardiac surgery. So coming to introduction, the congenital heart defects, it affects nearly 8% of the worldwide population. So the most common is the AST and the VST. And 30% of the affected congenital heart defect has some form of extracardiac anomalies requiring some form of non-cardiac surgical interventions before 5 years of age. And the most common non-cardiac procedures will be GI and the ENT procedures. So if we look into the pediatric health information data system from the USA, as you can see, the total non-cardiac encounters have increased from 38,000 to 45,000. This has happened over a period of 5 years, that is 2015 to 2019. And at the same time, the mortality ratio has also come down to 1.06. So this is mainly because of a lot of technical innovations and advancements that have been done so far in the past decades. And also due to the multidisciplinary approach that is being done in the pediatric congenital heart defect coming for the non-cardiac surgery. So before going into the intraoperative management, we will look into the P-anesthetic evaluation. So the P-anesthetic evaluation, it is very important because we need to have a proper rational anesthetic plan. For that, we need to be familiar with the key elements such as the child's medical history, the physical examination and investigations, so that we can tailor the intraoperative management. And not only that, we need to give an in-depth education to both the children and the parents before the planned intervention. So this is, as I have said before, the multidisciplinary approach in the planning, preparation, and the conduction of the surgery. It's very important, especially in the subset of patients who are coming for a non-cardiac surgery. So similarly, like how we do a heart team meeting in a cardiac surgery, in a similar way, a heart team meeting should be done for non-cardiac surgery as well. So this includes the group of subspecialties who are involved in the management of the patient, so that this will help us in optimizing the survival of the patient and also help us in understanding the lesion. So why it is important? Because few of the complex lesions might not be well understood by the non-cardiac surgeons as well as the pediatric anesthesiologists. So if we sit together and talk, we can understand the lesions better, and also we can make the best approach or the intervention for the child. So as a part of pre-op evaluation, we have to look for the history and the physical examination. So in terms of history, the child's functional status is almost equivalent to the cardiopulmonary reserve. So the functional status is assessed differently at different ages. So in case of neonate and infant, we have to look for the feeding difficulties, tachypnea, dyspnea, diaphoresis, failure to thrive, and frequent respiratory tract infections and growth abnormalities. And in case of school-age children, we have to look for decreased activity level, exercise intolerance, inability to keep up with their peers. And in case of older children, since they are able to verbalize the problems better, we can ask for chest pain, palpitation, dyspnea, orthopnea, easy fatigability, and pre-syncope and syncopal-like episodes in long QT syndrome. So out of all the important history, the utmost importance should be given for frequent respiratory tract infection, because the recent or active infection is found to have an increased airway-related complications such as laryngospasm, bronchospasm, and breath holding. So these happen not only during induction but also during extubation. So it is always prudent for us to give a period of recovery, that is 2 to 8 weeks, in case if we find a recent an LRA or active LRA for elective procedures. So coming to the physical examination, it will further assess the child's general condition. So observation is one of the valuable component of the physical examination. So we have to look for the vital signs such as heart rate, NIBP, temperature, respiratory rate, and saturation. And NIBP and saturation has to be measured both in the upper limb and the lower limb in case if we suspect a left aortic arch pathology like a coarctation, and it has to be measured in a bilateral upper limb in case if there is a systemic to PA shunt. And also we have to look for the quality of the intravascular lines and also the arterial line access for the invasive lines. And in terms of general examination, we have to look for height, weight, and obvious syndromes, and look for the degree of talar, icterus, cyanosis, clubbing, and the pedal edema. And detailed system-wise assessment should be done. So in case if the child has already undergone a cardiac pathology, then we have to look whether it is a repaired or a palliated one, and any previous history in terms of anesthesia and surgical history, and along with its complication has to be looked for, and also look for the therapeutic interventions, current and past medications. So one important thing that we have to note for any obvious syndrome, because the obvious syndromes are like a Pandora box. When we open one defect, the chances of another congenital malformation is also very high. So these are various congenital, common syndromes that we have, which is associated with the congenital heart defect. So in terms of cardiac examination, a few points that I would like to emphasize is to assess the functional capacity, including signs or symptoms of congestive heart failure. Rise JVP is less significant in neonates. Look for any progressive cyanosis or cyanotic spell that will suggest a rapid cardiopulmonary decompensation, and also general examination followed by auscultation. So always remember, heart sounds are influenced by the patient positioning. So in terms of respiratory system examination, other than the auscultation, we all have to look for the use of steroids in the recent past, history of chest or airway surgery, history of bronchopulmonary dysplasia, because these kids will be on preoperative O2 therapy, so that sedative pre-medication has to be carefully administered, and diuretics also, they will be having electrolyte imbalance, and any upper airway malformation, anatomical issues, and history of sleep apnea. So they all have an implication on our airway management, and look for obstructive diseases like asthma and restrictive like kyphoscoliosis. So one importance in terms of respiratory system is to be given for premature infants. So recently, because of the increase in the NICU graduates patients presenting for anesthesia evaluation with the disease of prematurity is high, and these kids have a very higher occurrence of apnea of prematurity along with the bradycardia. And not only that, they have a developmental delay, difficulty in the IV access, and parents must be counseled for post-op, increased chance of post-operative ICU stays, mechanical ventilation, and increased chances of post-operative monitoring. So in terms of airway evaluation in congenital heart disease patients, it is found that there is an increased incidence of airway-related problems. So this is mainly because of the craniofacial syndromes that the child might have, like a trisomy 13, 18, 21, Di-George syndrome, Turner syndrome, Treacher-Collins, and Golden heart, and also because of the airway compression, that is the vascular problems. So these are various vascular causes of airway compression. So always remember, these vascular compression will be dynamic in nature. So it can affect in any part, like in trachea, or it could be in the bronchi. And most common presentation will be like a tracheobronchial malacia and stridor. So these all things have to be kept in the mind, because they will not only trouble us during intubation, but also during extubation, resulting in extubation failure. And any previous airway interventions, complications, and previous surgery to the face and neck should be also looked for. And this is again a large centric study that's been done by Sebastian et al. So from a practical standpoint, patients with a congenital heart defect will have a very higher Cormack-Lehen grade 3 and 4, and this is very higher in age less than 1 year. It's almost about 5% when compared to age more than 1 year. So this is again an entire picture showing about the other non-cardiac anomalies in a pediatric congenital heart defect. So this is in 2018 by Neidenbach and their colleagues. They actually found that there is an increase more than 95% incidence of non-cardiac anomalies in a pediatric congenital heart defect, and the most common is found to be the endocrine abnormalities, followed by GI, followed by vascular, and the skeletofacial abnormalities. So coming to the risk stratification, like how we do for a cardiac surgery, like a RAC scoring, and a similar way for a pediatric cardiac coming for a non-cardiac, we need to stratify the kid, because the stratification is going to help us in identifying the complex problems, so that we can anticipate any risk that is seen in managing them. So according to Farani et al., so he has given a few lesions like single ventricle circulation, complex defects, pulmonary hypertension preoperatively, and congestive heart failure child, and outflow tract obstruction like an LVOTO or RVOTO. These patients are at a very high risk. And whenever we are called for managing these kids, we have to be always in our tip of toes when we are managing. And not only that, Farani et al. Has given a composite scoring system that includes a severe congenital heart defect and single ventricle physiology, surgery within 30 days, inotropic support, preoperative CPR, acute kidney injury or chronic kidney injury, mechanical ventilation, and emergency procedure. So based on that, the scoring less than 3 is considered to be low, and more than 3 is considered to be medium and high. So this is again another one stratifying categorization of severity based on the American College of Surgeons, the NSQIP. So what they have told is the child whose uncorrected cyanotic congenital heart defect, the documented pulmonary hypertension, or an LV dysfunction listed for a heart transplantation. So they are at a very major risk. And followed by that, the child with an unrepaired cyanotic heart defect, like TOF, with a free TOF, or repaired but with having a residual defect like a free PR, or like a well-functioning fontan. So they all considered to be like at a medium risk. And any unrepaired like a simple VSD, ASD are considered to be like a minor category. So one important question that we always have is when to call a pediatric cardiac anesthesiologist. So this is again a flow chart given by the ASA. So unless it is not an emergency, we have to risk stratify them. So in case if it is an emergency, Glenn Fontaine or an inotropic support, preoperative CPR, AKA or CKD mechanical ventilation, the scoring, if it is more than 3, we always have to keep a pediatric cardiac anesthesiologist for consultation. And not only that, the surgery should be done in a tertiary care with a multidisciplinary discussion that should be done with the relevant clinicians. And always we have to discuss the potential for deployment of the ECMO, because always remember, in a complex lesions like a Fontaine circulation, CPR is definitely not going to help. And only thing that is going to help is the eCPR, that is rapid deployment of the ECMO. And also we need to talk about the postoperative inpatient monitoring now. So coming to the preoperative medications, these are the drugs that needs to be continued. That is the beta blockers, anti-seizure, anti-PA drugs, and thyroid replacements. And diuretics should be definitely withheld on the morning of the surgery. AC, ARB, and RNA inhibitors should be withheld 12 to 24 hours prior to the surgery. And in case of anticoagulants and platelets, we have to have a discussion with the cardiac surgeon. And in case if it is urgent procedure, or if the patient has already underwent a BT shunt or something previously, if the patient is having any conduit thrombosis, then definitely we need to continue the aspirin till the surgery time. And in case of infective endocarditis prophylaxis, the infective endocarditis prophylaxis is indicated for a child with a previous history of infective endocarditis, or if the child is having a cyanotic congenital heart defect which is unrepaired, or even if it is repaired but within 6 months of period and repaired with the residual defects, and also in cardiac transplant recipients with a cardiac valvulopathy. So this is again regarding the antithrombotic therapy. There is currently no specific guidelines to discontinue the antithrombotic medications, especially in these kids. But if we suspect if the child is having an increased risk of thrombosis of the shunt, like a BT shunt, then definitely we need to continue the aspirin. And the vitamin K antagonists such as warfarin can be discontinued 5 days prior. And in selective cases, we need to consider bridging with a low molecular weight heparin or an unfractionated heparin. And again, in direct oral anticoagulants such as dabigatran and rivaroxaban, it should be stopped 2 days prior without any bridging. And in antiplatelets, clopidogrel should be stopped 5 days and ticagrelor or 3 days. And once the bleeding risk is low, we have to restart the drugs in the postoperative period. And in case of emergency, we have to consider vitamin K injection FFP, prothrombin complex concentrate, and use the point of care tests such as PEG and ROTAM to analyze the coagulation pathway. So in terms of preoperative lab investigations, so complete blood count, we have to look for erythrocytosis, which is secondary to cyanosis, anemia, secondary to malnourishment, and in renal function test and TFT should be done in Down syndrome. And serum electrolytes, hypokalemia and hyponatremia, secondary to diuretic therapy. And neonates definitely have a very high risk of hypoglycemia. Blood glucose should be checked in serial basis, and also hypocalcemia and Digeorge syndrome and parathyroid dysfunction. And coagulation study, like a platelet count, APTT, PTINR, serum fibrinogen, especially if a child is polycythemic, always remember the megakaryocyte production is low and they have a low platelet count and they are at a very high risk for bleeding. And we have to do the coagulation study. And screening and blood grouping should be done for all the patients. And ABG, in case the child is very sick and having a ductal dependence, systemic circulation, or a congestive heart failure. So in terms of preoperative imaging studies, the tests such as chest X-ray, ECG, and echocardiography is invariably done for all child. In case if it is a complex lesions, like we need to look for the detailed cardiovascular morphology or valvular pathology or myocardial valve perfusion or viability, then we can consider doing CT. And MRI is mainly done for looking for the ventricular volumes, especially in complex lesions, regurgitation fraction, looking for a pulmonary blood flow and QP/QS. And in case if the lesions is very complex, we might need to do a cardiac cath also before the child is undergoing a non-cardiac surgery in elective patients to look for the degree of increase in the pulmonary vascular resistance, ratio of the RV and the LV pressure, response to the pulmonary dilators and shunt directions, and also ventricular functions. And other imaging based on the pathology has to be asked for. And in the preoperative period, imaging is mainly not only done to confirm the cardiovascular anatomy and the pulmonary vascularity, but it's also used for determining the RV patency, positioning of the vital catheters and tubes. So this is an image of an X-ray. On the left side, we have a very large AST with arch pathology showing a pulmonary plethora. And on the right side, we have a TOF showing the oligemic lung field. So again, if the child has already underwent previous cardiac surgery, we can ask for a lateral X-ray. But in case of non-cardiac surgery, the lateral X-ray is also going to help us by looking, by showing us any vascular mediated airway compromise. So again, X-ray can be also useful to look for the location of vascular lines, especially in small infants with umbilical vein catheter and umbilical artery catheter, and also look for any cardiac rhythm management devices. The positioning, the lines, the AICD, and the pacemaker leads can be also looked for. So echocardiography is very important. In case of non-cardiac surgery, we have to look for the structural abnormality, function of the ventricle chamber size, as well as the physiological parameters. And always the echocardiography in pediatrics have its own standard reporting process, such as the first step will be to tell, they will note down the visceroatrial status, the position of the atrium to the abdominal anatomy, and the second step, the orientation will be given, and third step, the atrioventricular and the ventricular-arterial connection will be noted. So, based with the repeated practice, we can easily read the report so that we can have a good understanding about the echo. And in case if we feel the echo is not very clear for looking for the arch anatomy and coronary artery, we can ask for advanced modalities such as CT and MRI. And 3D, now we are in an era of 3D, and 3D echo for the assessment of the valves and congenital heart defect is very much useful. So in terms of ECG, a 12-lead ECG with an adequate length of lead 2 is important, and we have to identify potential rhythm or conduction abnormalities, including pre-excitation that happens in Epstein's anomaly, and assess hypertrophy in case of TOF. So always we have to have a baseline so that any changes in the postoperative period can be suspected. And in case if there is an arrhythmia, we can go for a 24-hour Holter monitoring. And in case if the child is on any cardiac rhythm management devices like an AICD or a pacemaker, always we have to obtain the data history of indication timing, type of the procedure, battery life, the standard nomenclature, that is the North American Society of Pacing and Electrophysiology, and check for the ECG for spikes and echo or X-ray for the leads positioning. So coming to the preoperative fasting guidelines, multiple societies have endorsed different practices. This is the ASA guidelines, we have European Society guidelines, but the Society of Pediatric Anesthesia in New Zealand and Australia, they have actually endorsed a very liberal practice of allowing clear liquids 1 hour prior to the surgery, that is about 5 ml per kilogram. And this is very important because especially in cyanotic kids where they won't tolerate the dehydration, in those kids, we can always allow clear liquids 1 hour prior to the surgery. And currently we are in an era of a point of care. We can always use a bedside ultrasound to determine the gastric volume in these patients. So coming to pre-medication, routine use of anticholinergics for the increase in the heart rate is not advocated. But in case if we are using the drugs like a ketamine, we can use anticholinergics for anti-sialagogue purpose. And sedative pre-medication, always remember it should be based on the clinical condition and the lesion, that is the pre-existing illness, respiratory compromise, congestive heart failure, and the cyanosis. And the most preferred drug is the midazolam. So oral midazolam, the dosage is 0.75 to 1 mg per kg. It can be administered. So in case if the child is not able to take orally, intramuscular injection can be done in the preoperative room before taking the child to the OR. And recently, intranasal dexmed is also considered as a choice. The intranasal atomizer, like 1.5 to 3 mics per kg, it is considered to be more safe and effective. So few little points about the little hearts. Pediatric cardiovascular system, the heart LV is immature till 6 months of age. Sympathetic nervous system is poorly underdeveloped and the catecholamine stores are already depleted. They have a predominant parasympathetic nervous system and myocardial contractile function is not developed in newborn and they depend on high calcium levels. Always remember calcium is an inotrope for pediatric heart. And not only the systolic function, but the diastology, that the compliance is also decreased. So their cardiac output is dependent on the heart rate and the sinus rhythm. And a few points about the series parallel and the single ventricle circulation. So in normal circulation, the deoxygenated blood from the RA-RV go into the PA, into the lungs for oxygenation and come back to the LA-LV into the aorta for the systemic circulation now. Whereas in parallel circulation, what happens is, especially in cardiac patients with a very significant shunt, there will be mixing up of both the oxygenated and the deoxygenated blood because of the shunt. And the amount of the blood to the pulmonary or to the systemic circulation is determined by the SVR or the PVR. So in case if there is a increase in the pulmonary blood flow, this is again the magnitude of the QP and the QS always is determined by the SVR and the PVR. So whenever the QP is high over a period of time, it will cause pulmonary congestion, thereby causing increased infection sources and also failure to thrive. And a few conditions like a TOF, there will be right to left shunt resulting in cyanosis where the QP will be lesser than the QS. And there is one other important category called as a single ventricle, where one ventricle provides both the systemic and the pulmonary circulation. So initially they will be parallel and once the Fontan palliation is done, the parallel circulation will be converted into a series circulation. And again, the QPQS actually depends on the stage of the palliation. So before the first stage of palliation, there could be either the pulmonary could be overflowing or it could be underflowing. And followed by the Glenn and the Fontan, slowly the parallel circulation will be converted into the series circulation. So there are numerous classification for congenital heart defect. One is the anatomical, other is the physiology. So for anesthesiologists, the physiological classification is most useful for us so that we can plan our management accordingly. And there are four main types based on the physiology. One is the simple left to right shunt with increased pulmonary blood flow, the ASD, VSD, PDA, and AV canal defect, and right to left shunt with a decreased pulmonary blood flow, that is the TOF, pulmonary atresia, tricuspid atresia, the Epstein's anomaly, and complex lesions such as truncus arteriosus, transposition of the great arteries, TAPV, PVC, and double outlet right ventricle and hypoplastic left heart syndrome. So these are considered to be complex lesions, and obstructive lesions such as coarctation of aorta, aortic stenosis, pulmonary stenosis, and HL, hypoplastic aortic arch. So coming to preoperative monitoring, the basic monitoring that includes the observation of the child, including skin color, capillary refill, respiration, pulse palpation, along with the looking into the surgical field and also the color of the blood that is shed, and also the standard non-invasive monitoring such as NI, BP, ECG, saturation, EtCO2, temperature, respiration, and anesthetic gas monitoring should be done. And in selective cases, we can go for centerline and invasive BP as well as ABG. So what are all the new technologies that we have? Again, we have the point of care ultrasound, that is the cardiac echo. We can always use it to look for the ventricle volume, systolic function, to exclude any hemodynamic decompensation that is happening in the perioperative setting. And in few selective cases, we can also go for cardiac output monitors. And this is always an option, especially in small neonates coming for a complex lesions and who's having a like a HLHS, hypoplastic left heart syndrome, all these kids who are not underwent a definitive procedure coming for an elective non-cardiac procedure. So coming to the pre-anesthetic goals, so our goal is to optimize the systemic oxygen delivery to maintain the ventricular function, to ensure the adequacy of cardiac output, but always keep in the back of mind that the potential for decreased cardiac reserve that is being there in this particular subset, and they also have a reduced tolerance for the perioperative stress. So always we have to carefully titrate the anesthetic drugs. So again, the choice of the anesthetic techniques, there is no specific technique is superior over the other. So general anesthesia is widely accepted. It's an appropriate choice for children undergoing non-cardiac surgery. And always we can club the regional anesthesia techniques such as blocks or giving a caudal epidural. We can always give it along with a GA. But one advantage with the regional is they have a good post-operative recovery. It's a more pleasant experience for a child. And not only the intraoperative period, but post-operatively also we can manage, and there is a decreased number of systemic medications. There is in general anesthesia, the main disadvantage is greater fluctuation that happens to the hemodynamics during induction and extubation and the prolonged recovery. Whereas in regional, even though its use is limited in small children, sometimes 100% we might not be sure whether our regional anesthetic technique have worked. And also in case if we give a higher blockade like a neuraxial blockade, there is a very potential hemodynamic compromise that can happen, and there can be a problem with interference with the coagulation. Always remember, read the ASRA guidelines and look for the ASRA guidelines before giving the regional anesthesia. So coming to intraoperative consideration of left to right shunt. So left to right shunt can happen in 3 levels. One is at the atrial level, ventricle level, and at the greater arteries. So these disease, they have found to have a very highest level of perioperative cardiac arrest according to the POCA registry. But still, once we completely, treat them with a proper CPR technique, their mortality is very low. So the left to right shunt, the defects, the shunting will happen based on the connection either at the arterial level or at the ventricular level and the greater arteries. So most commonly, the SVR, since the SVR is higher than the PVR, the blood flow will be happening from the left to right, and it will cause an increased blood flow. So this will actually cause pulmonary congestion and congestive heart failure. But over a period of time, the long-standing left to right shunt will cause increase in the pulmonary vascular changes, resulting in pulmonary hypertension, and the QP, increase in the QP will cause increase in the PVR, thereby reversing the shunt, resulting in Eisenmenger syndrome. So the intraoperative consideration is again the IV drugs, there will be continuous dilution because from the left to it will go into the right. Whereas the inhalational drugs, the speed of induction will be little bit high unless the cardiac output is not affected. And always remember, these kids have a very high degree of RV overload or failure. This is always underappreciated. We always take it, it's just a ASD or a VSD, but always we have to remember this, especially during the induction time. and avoid 100% oxygen, because increase in the FiO2 is going to increase the pulmonary blood flow and thereby increasing the congestion, resulting in flash pulmonary edema. This can happen even during induction, and also avoid hyperventilation. So propofol, thiopentone, ketamine are the drugs of choice. And the goals of left to right shunt is to maintain the SVR, increase the PVR so that the pulmonary blood flow will be under control. So we have to minimize the positive pressure ventilation and increase the PEEP so that the PVR will be higher, and also lower the FiO2, decrease it to 0.3 level. And ketamine, it increases SVR but also increases the PVR. It can be used as a drug of choice. And inhalational agent, they decrease the SVR. So the other than the arterial level and the ventricular level, always remember the shunting at the greater artery level in the neonatal period will always will be seen in the neonatal period, like a large PDA. So these kids will be coming in the neonatal period for some form of non-cardiac surgery, like tracheoesophageal fistula or esophageal atresia or a CDH or a necrotizing enterocolitis. So whenever there is a large shunting that is happening at the greater artery level, so always we have to be careful because there is an increase in the pulmonary blood flow. What happens is the diastolic blood pressure will be very low. If we are not regulating this PDA, what happens is that the QP will be very high, and the diastolic blood pressure will fall, and this will in turn reduce the coronary perfusion pressure, because of the coronary perfusion pressure will depend on the diastolic blood pressure and thereby causing the myocardial ischemia. So always remember this in the back of mind when we are managing these kids. So coming to intraoperative consideration for right to left shunt, the most common is the tetralogy of Fallot. So there are four main components, that is the RV hypertrophy, RV OT obstruction, VSD, and the overriding aorta. So the obstruction of the right ventricular outflow tract, it increases the right ventricular pressure, thereby the deoxygenated blood, it passes through the VSD into the overriding aorta, causing the cyanosis. So the classical top is at the level of the infundibulum, and what happens is over a period of time the cyanosis will worsen, and in case if there is any sympathetic stimulation or any changes in the volume like a hypovolemia or a dehydration, the patient can go for a TED spell. So these are the various consequences of cyanosis. The oxygen saturation will be less than 85%, and because of this there will be secondary polycythemia due to increased RBC production at the kidney level, thrombocytopenia, low factor 5, and von Willebrand factor, high INR, and APTT. So these are the few important consideration to consider for right to left shunt. One is we always have to give them adequate hydration. Avoid any prolonged NPOs, because these kids definitely will not tolerate prolonged NPO. If there is an IV line, you have to start a maintenance IV fluid. And inhalational induction, it is prolonged by the limited pulmonary blood flow, whereas the IV induction will be rapid due to the bypassing of the pulmonary circulation. And always remember, if you get an uncorrected cough, it is like a major procedure, and always avoid, they will very poorly tolerate the neuraxial blockade, and always proceed for a general anesthesia. And these kids, they will require some form of, like a shunt, like a BT shunt to maintain the pulmonary blood flow. And these kids might be on BT shunt, and they are also at a very high risk of paradoxical embolism. We have to be very careful while giving any IV drugs, avoid any air emboli, and maintain the sinus rhythm. So in case if the child is having a TED spell, give 100% oxygen, fluid bolus. In case if the child is awake, we can give a knee chest position, or else if it is intubated, we have to look for what is the cause. If it is a sympathetic stimulation, you have to deepen the plane of anesthesia, give some opioids and phenylephrine for the increase in the SPR, and also reduce the infundibular contraction with a short-acting beta blocker such as an esmolol. So the goal is basically to increase the blood flow, pulmonary blood flow, by increasing the SVR, so that we are giving a phenylephrine, and decreasing the PVR. So, and also avoid any increase in the PVR such as hypoxia, hypercarbia, hypothermia, acidosis, vasodilators, and sympathetic stimulation. So in case if the child has already underwent a BT shunt, like a tough child with a BT shunt coming for a non-cardiac surgery, so this subset of patients, they have a very fragile physiology, because they are actually like a double-edged sword, because the BT shunt basically maintains the flow from the subclavian system to the pulmonary system. So in case if there is anything that is causing a decrease in the PVR, what happens is there will be a diastolic runoff that will be happening into the PA, and this will actually cause the decrease in the diastolic blood pressure, thereby causing a coronary hypoperfusion. And the other important part is these patients with a BT shunt, they are having a very high risk for thrombosis. So always, if you get an elective surgery, you have to defer these patients unless it is not an emergency till they get the first stage of palliation, that is like a Glenn. And in case if they are taken for a surgery in the OT, we always have to be careful, look for the shunt murmur, and also meticulously plan in such a way to avoid the risk of shunt occlusion. And in case if the shunt occlusion happens, so this will be indicated by the worsening of the hypoxemia despite higher oxygen, and also suddenly there will be increase in the blood pressure because the diastolic running off is not happening, and there will be drastic fall in the ETCO2. So the diagnosis is by the shunt murmurs, which was previously heard, will not be heard, and we have to give quickly heparin 100 international units per kilogram, and quickly give a call for a pediatric cardiologist, and might need to ship the patient to the cath lab for angioplasty, stenting, or thrombolysis. So for a BT balanced circulation, we need to keep the PVR high, FiO2 at a very lower level to maintain the saturation of 80 to 85%. Minimize the mechanical ventilation, FiO2 of less than 0.3, ETCO2 35 to 45 centimeters of water. And in case of any severe hypotension due to the excessive pulmonary blood flow, we might need to start some inotropes such as vasopressin, calcium, and epinephrine. So the last one, that is the intraoperative consideration for single ventricle. So these are diverse group of lesions. They have like a truncosarteriosis, the pulmonary, tricuspid atresia, pulmonary atresia, double inlet LV, DORV, and that is the double outlet RV, hypoplastic left heart syndrome. So these are group of lesions which are very, very difficult to understand, but still whenever we get a case like this, we have to read and go so that we can understand the lesions better. And always remember the POCA registry, that is the perioperative cardiac registry, has given a 19% of perioperative cardiac arrest for all these lesions which are uncorrected. And these lesions, the source of the pulmonary and the systemic blood flow are determined after the birth. And few lesions, we might need to open up the PDA in the form of prostaglandin infusion or a stenting like a HLHS, that is the hypoplastic left heart syndrome. And few lesions may require a PDA-dependent pulmonary circulation, like a pulmonary atresia or tricuspid atresia, either in the form of, like a PDA stenting or a BT shunt. And other lesions might have an unrestricted pulmonary blood flow, so they might need a PA banding. So in case if we get these patients for the surgery, sometimes we might get either prior to the surgery itself, prior to a proper definitive surgery, like in like a neonates coming for an emergency procedure. So these patients, the PDA dependent lesions, we need to continue the prostaglandin infusion. And always remember, PDA will be overflowing if there is decreased PVR. So we have to balance the PDA circulation. And other lesions may have an unrestricted pulmonary blood flow. So in these patients, we need to increase the PVR. So we have to increase the PVR by maintaining minimal FiO2 saturation of 85%. Avoid hyperventilation and ETCO to 35 to 45. And these kids, NIRS will be helpful. And ABG and invasive lines should be kept, an inotrop in case if there is a persistent low blood pressure. So there is a second subset of patients, that is the patients who come for us after first stage of palliation, that is the BT shunt, Sano shunt, RV to PA condio, or a PDA stenting. So these kids, our anesthetic implications are as discussed before, like TOF with the BT shunt coming for a non-cardiac surgery. And there will be another subset of patients who will be coming for us after a Glenn or after a Fontaine. So this stage is actually ideal for a non-cardiac surgery. So we can, any elective procedure, we can wait till the Glenn, because in these cases, the BT shunt will be taken down and the PA will be supplied by the SVC in case of Glenn, and IVC and SVC in case of Fontaine. and the heart or the ventricle will be offloaded adequately, and the catastrophe risk for shunt occlusion or thrombosis is not present, and any functional single ventricle with the cyanosis, we can accept the saturation of 75 to 85%, and the patients with the Glenn will be more resilient because the ventricle is offloaded and the cardiac output does not rely completely on the pulmonary blood flow. And in terms of the echo, carefully we have to review the preoperative ventricle function and aortic valve regurgitation, because they will be at a very high risk in case if the LV is depressed or if there is a severe AV valve regurgitation. So in terms of Fontan circulation, all the systemic veins are routed into the pulmonary artery. So one important implication in Fontan is we have to maintain an adequate preload, because without a proper preload, the single ventricle may not be able to pump enough to the entire body. So we need to maintain the adequate preload. The CVP should be maintained at least 15 above, and patients also will not tolerate any acute blood loss, vasodilators, or prolonged fasting. And a few Fontan patients, there will be tunneling. That's one other procedure that will be done where the Fontan, there will be penetration, there will be tunneling, which will be done to the RA, and these patients are at a very high risk for arrhythmias. And in case of any hypotension, always keep a touch of a vasopressin or an norepinephrine, and have a balanced ventilatory parameters. And always remember, Fontan is only a palliation or a repair, and it's not a definitive procedure. And some of these patients might be listed in the heart transplantation as well. So special consideration like Asian major, so where we need to minimize the pulmonary vascular resistance because of the increased PVR, the shunt reversal has happened. So 100% oxygenation should be given, maintain the SVR, and we might need to use some vasoconstrictors. In case of peripheral procedures, we can go for regional anesthesia, but if it's a general...
Dr. Maithriye, how much more is there?
Sir,
I think you have to go for the conclusion slide now.
Yes, sir. 2 more slides, sir. That's
I think we have to go for conclusion because will not have any time for discussion.
okay, sir. So to conclude with anesthetic management for pediatric congenital heart defect for non-cardiac surgery, the attention should be paid for child's overall development and the presence of any syndrome. So, and notably, any recent respiratory tract infection will have a drastic effect on our perioperative period, and we have to look into the complex heart lesions. We have to look for the perioperative investigations and monitoring techniques so that we can plan the entire perioperative period, and also look for other concerns such as peripheral access, airway, and complex physiology like simple single ventricle. Thank you.
Thank you, Maithriye, for that exhaustive presentation, and really you touched upon every topic, saying that even if it is not preoperatively corrected, they still can have cardiomyopathy, like in cases of Al-Kappa, where there is dilatation and valvular regurgitation, and in cases of patients with adult type of tetralogies or even little grown-up tetralogies who can have hypoxic myocardiopathy, which can affect even if you're taking it for cardiac surgery itself, coming off bypass, and maybe quite difficult in these kids. Very nicely presented and touched upon all the parts of the topics. Now, over to Dr. Muralidhar for the discussion.
Thank you so much. Thank you very much. All the speakers have done very well. And I would request all of you to switch on your videos. And then if the screen is unshared, then it will be better. Maithriye, please unshare the screen. And I request Minati and Manjula Sarkar to pass their comments, and any questions
As first lecture was of Dr. Karthik Babu, I say that that was a really excellent lecture. He has covered everything to the point, crisp, and what anesthesia considerations we should keep it in our mind in
Yes.
such kind of the situations. Regarding Dr. Jothinath is concerned, I liked his slides very much. Appropriate slides with good, that examples to understand the topic for the beginners. It was really very nice. And regarding Dr. Anusha is concerned, as she said that this is a multidisciplinary approach, so we have to really take a whole team into the consideration, cardiologist, obstetricians, anesthesiologists to deal with cases, because most of the time these cases are coming, asymptomatic, and on table we are finding some adverse cardiac event, and then we are coming to know, oh, this is the case of dilated cardiomyopathy. So we are really in soup and we really don't know how to tackle it. So we have to really careful, and every patient we can't just take the extensive investigations done to find out whether the patient is having the disease or not. So we have to be really careful for that. And regarding Maithriye is concerned, she has really given the extensive, exhaustive talk, as Dr. Krishnamurthy said. This is really a good presentation. But few points I want to know from her. In centers where the cardiac setups are not that good and pediatric patients are coming for non-cardiac surgeries, emergency surgeries like torsion of testes or neonatal obstructions. So what minimum monitoring you should advise, or whether these patients should be shifted to the cardiac centers for the treatment, or we should deal it in those centers where the cardiac setups are not there?
Ma'am, based on the non-cardiac surgical procedure, we can go for the AAC standard monitoring, ma'am. If we are
So
having
if the torsion of testes patient has come, 6 months old patient, and we do not have the cardiac setup in our center where we are working, so what minimum monitoring should be done, and whether we should accept this patient or not, or whether we should transfer this patient to the higher centers?
Ma'am, if it is an emergency, we can do it in the non-cardiac setup as well, because we can have NIBP, or we can have the pulse plethora saturation. We can also look for the gas monitoring, ABG. In case if the center can have an ABG monitoring, we can take a serious sampling. We can give and we can do the procedure. But once the surgery is done, for the post-operative monitoring purpose, we might need to, shift the patient to a cardiac center, because of the multidisciplinary team, which will be there to take care of the patient post.
Suppose the patient has been taken for exploration and start bleeding. So, what is the role of the synthetic fibrinogen in these kind of the situations?
You're asking about the factors, ma'am, like a factor.
Yes.
In case we can use FFP, ma'am, we can use FFP. And in terms of the factors, like a factor 7A, currently it is not recommended, because they have a very higher chances of thrombotic occlusion, because it is like a risk versus benefit. And we are at a very high, there is a high risk of shunt occlusion that might cause immediate cardiac arrest. So that is what we are worried about more. In case if we are having like an FFP, we can use that, and a point of care testing can be also done if possible.
And minimum monitoring, you mean to say the ASA guidelines monitoring we should
ASA
do?
standard monitorings we can have.
And emergency cases should be dealt wherever they are.
Yes, wherever they are.
Okay. Minati.
Nice presentation, all of you. And Kaushik Jothinath, excellent depiction of all the things and excellent explanation. And regarding cardiomyopathy, peripartum cardiomyopathy, again, one can go for, there are a lot of reports, but as such, there is no standardized study and all. One can go for all the kind of anesthesia in a graded manner. One can go for GA or epidural or spinal or combined spinal epidural. There are a lot of discussion about all these things and in different literature. Again, most of the authors, they said the outcome is good in all the cases. Even one of the authors, they did 4 elective cesarean section who was dilated cardiomyopathy, and they're very extremely sick patient, less than 25% ejection fraction. They did all the cases under GA with a graded dose of propofol, scoline, and fentanyl, and the outcome was again good. In all the cases, they manage not only these authors, the other authors, whatever they have described, they manage with some use arterial blood pressure, some does not use simple NIBP, and all are gas monitoring and CBP. They manage all the cases without any adverse outcome. But one should be very cautious regarding while using the propofol in these such kind of cases, because cardiac arrest is very common with high dose of propofol. And again, avoid high concentration of volatile anesthetic, atropine, ephedrine, because they may uh, alter the hemodynamic at times, which is uncontrolled to manage. So congenital heart disease for non-cardiac surgery, again, it is very, very challenging, especially the cases with balance circulation. They are very difficult to manage at time because you have to manage both the things. But here also there is no as such evidence. There is no randomized trial or there is no recommendation. So there is no single approach is best, and you have to see what is the situation of your patient. If you don't have any facility, better if it is elective case, you postpone the case, take a multidisciplinary approach, discuss with a cardiac anesthesiologist, surgeon, intensivist, and the cardiologist at the same time. Take everybody in the panel if you have a cardiac facility. If doesn't have a cardiac facility, it is a elective surgery, then you can always shift your patient to a cardiac center. And again, no single approach is the best. There are multiple things has been described in the literature with permutation combination of the drugs, and even regional in the kids also with the congenital heart disease. But it all depends upon the team. In case of emergency, again, as you said, standard monitoring, but it's better to shift if the patient is very sick, especially the balance circulation, shift to another center.
Sir, Dr. Kanchi, final conclusive remarks.
Sir is not there.
Sir is not there.
Yes, sir.
Okay.
Again, the stenotic lesion, especially the aortic stenosis, for the non-cardiac surgery, the asymptomatic patient, they do better. They have very less adverse cardiac events later on. But symptomatic, again, if it is elective surgery, one should postpone the surgery and fix the valve first, then go for the non-cardiac surgery. If it is a emergency surgery, again, you have to take a high risk consent and all the monitoring and your graded anesthesia approach. And in all the valve case, again, you have to avoid hypoxemia, excessive hypotension, tachy, dehydration, brady, or volume overload. You have to balance all these things, which is nicely described by Dr. Jothinath.
So, okay, then everybody has done the good job. And I hope that audience will get the benefit after listening this webinar. So I thank everybody on behalf of ICA, and Madam Sood is there on the side.
I don't think so, ma'am.
No, so
No,
then
ma'am is not there.
okay. So thank you very much to you all, and we
Thank you,
are
ma'am.
just Thank you, Dr.
Thank you, madam.
Jothinath,
Thank
Dr.
you all
Karthik
for
Babu.
wonderful presentations. And I think somewhere sir has got disconnected or some problem. Thank you all. Have a good night and meet you in the next meeting. Thank you all.
Yes. Good night,
Thank
everybody.
you. Thank you. Thank you for the opportunity.
Thank you so much, everyone, for giving us the opportunity to host the session. Good night to all of you.